Dear students, today we'll discuss about surgically very important topic, that is wound healing. It's a day-to-day surgery. We'll always get wounds. That is the main objective of treating any patient. If you do a surgery, there will be a wound that has to heal. So you have to look into that. Look at the factors which affects. And patient may have a accidents. Patient may have some other reason. Wounds everywhere in the body, maybe skin, deeper tissue, bone, organs, elsewhere. So in the body, any tissues. So this is a very important topic for surgery. Finally, at the end of the day, surgeons are dealing with the wounds. That's why this is important. So if it is so, what is wound? Before wound healing discussion, just discuss basic thing about the wound, its classification, then straight away go to the wound healing. Basic concepts of managing. For details, you can always read my manual of surgery, chapter 2, and also you can go through my Digino lectures in surgery, in detail lectures about wound healing, wound through JP publishers. So wound, what is wound? Definition is very important. So that is the basic thing. So wound is disruption of tissues structurally and or function. That's the basic definition. Now tissue may be anything, skin, muscle, bone, or organs like liver, kidney, brain, thoracic wall, fracture, anything. So wound is finally disruption of tissue, whatever way, internal, external, whatever it is. So that is the important definition of the wound. So that this definition is very, very crucial. So wound is different from ulcer. Ulcer is a type of wound because ulcer is a disruption or discontinuity in epithelium or lining. Whereas wound is very gross terminology. Any tissue can get involved. Ulcer is one of the types of wound. There is a difference which you have to remember. So classification of wounds, Rank and Wakefield, good old classification, tidy and untidy. Tidy is clean wound, like incisor wound, maybe lacerated wound without much contamination, whereas untidy is contaminated, lacerated wound, and crush injuries with the contamination wounds. All those things are the untidy wounds. So this is a very basic classification, very important classification which you have to remember, because tidy wounds easier to manage, does not require much antibiotic coverage, may not require admission if it is superficial, and heals faster and simpler. Whereas untidy, it is not so. Depth may be important, it is contaminated, so you may have to do a proper wound debridement, then you have to assess the wound depth, extent, everything. So accordingly you have to manage. So untidy is more crucial, more difficult to manage. This is the point which you have to remember. So based on the type of wounds, I already told: clean incisor, lacerated wound, crush wound, deglowing injury, deeper wounds, contusions, hematoma, abrasion, penetrating wounds, stab injury, they are penetrating wounds, traction avulsion injuries, like brachial plexus injuries, entire getting avulsed, scalp getting avulsed, whereas limbs may go in between the machine and may get avulsed and may get crushed also. Crush injuries, crucial blunt injury, blunt injury abdomen, blunt injury thorax, blunt injury head. So all these things are very important. Maybe major, all these things are the maybe major injuries also. So depth is very, very important in this patient to assess. So it may be closed, open, or complex. So closed is deeper wounds, open is outside, complex is in combination with the nerve or vessel injury and so on. So major structures are injured, that is called as complex. So that is more difficult to manage. You have to really find out what exactly is injured. So classification based on thickness of the wound, maybe superficial, partial, full thickness, deep, complicated wounds, penetrating wounds. So there is another definition based on structure involvement, simple wound, combined wound, one or more organ, or complex wound. Simple is only one organ or one tissue involved, whereas complex is combined or complex is more than one organ, one tissue. Rather, they are major injuries. So based on time elapsed, acute wounds are those that progress through the normal phases of healing and show signs of healing in less than 4 weeks. So it heals faster, maybe simpler wound. Whereas chronic wounds are not so. Healing does not occur within the expected period according to histology and localization. So it is not exactly 4 weeks and beyond. Usually acute wounds heal by 4 weeks. But it does not mean that just beyond 4 weeks it is chronic wounds. Chronic wounds, suppose such wounds we may expect it to heal in 5 weeks. So differences are there, but 4 weeks is a usual traditional landmark. Not exactly it's a defined landmark. Usually it is. Actually, chronic wounds are wounds which have not healed in the expected period to that particular area. That's important. And to the specific etiology, particular localization and etiology. This particular area, this wound should have been healed by this time. If it is not healed by this time, beyond that it has taken to heal. That means it becomes chronic wounds. So it is not a specified time. Individual areas, individual conditions, this chronicity will be defined differently in individual patients. So there is a point. So it is not 4 weeks. 4 weeks is the usual timing. It is may not be always same. So there is a lot of debate, lot of question mark about these 4 weeks. That is the answer for that. Chronic wounds can be classified as, again, chronic may be typical, atypical. Typically is very specific wounds. Atypically is in immunosuppressed individuals, in vascular problems, and arthritis, rheumatoid arthritis patients. So many conditions they are called as atypical, typical. This is the classification. You can always go through my manual of surgery for a detailed classification of wounds as such. So again, it is classified Berard wound classification. Otherwise, it is called as CDC grading, Center for Disease Control and Prevention, CDC grading. Clean wound, clean contaminated wound, directive. This is the one which surgeons are always interested. Classification of surgical wounds. It's a commonly asked MCQ, theory they will ask, Viva they will ask. So we should know what are the classification. Surgical wound classification means clean, contaminated wound, dirty wound. Clean is like incisor wound, clean. Surgery in a lipoma excision is clean. Clean contaminated may be appendectomy without perforation. That is clean contaminated. Thyroidectomy is a clean wound. Hernia is a clean wound. So like that. So clean and contaminated wound is just suppurative appendicitis. That is maybe contaminated. Whereas dirty wound is full-fledged peritonitis. That is dirty wound. Empyema, dirty wound with pus formation, or infected large necrotizing fasciitis. That is dirty wound. Abscess. That is dirty wound. So like that it is classified. So clean, contaminated wound, dirty wound. So infection rate in each is different. So it's very less in clean. It increases as it progresses to dirty wound. So that is why this classification is most important for surgeons actually. So different types I already told. This is abrasion, this is the lacerated wound, this is a jaw trauma, hematoma. Lacerated wound is the crush injury. Some crush is there here, crush injury. And avulsion injury. See that it's called avulset. This is the typical look of the lacerated wound. This is the with the hematoma here, jaw mandible fracture is there. So the typical look of abrasion. Look at that. And hematoma. Look at that. It may be close to the blunt injury also, close to the deglowing injury also. But usually it is a typical look of the hematoma. May treat conservatively, but may have to evacuate the hematoma as such. So wound healing. So once you know basic about the wound healing, wound as such, then wound healing comes, because what are the different stages of wound healing? What are the different methodology how body tries to heal the wound? And as a surgeon, as a clinician, what are your responsibility to promote this wound healing by treatment, wound wash, wound debridement, wound suturing, or further putting flap, vac therapy, whatever it is. So what are your roles to make the wound heal faster? That is the point. It's about wound healing. Briefly, I will discuss. Wound healing is complex process. It's very complex process to achieve anatomical and functional integrity of disturbed tissue by its various components. So what you are going to achieve? Anatomical. I said it is a definition. Initially, I told in beginning, wound is defined as disruption of tissue structurally and functionally. So wound healing is complex process achieving anatomical and functional integrity of disrupted. Tissue has disrupted, there is a wound. So you have to attain the anatomical and functional integrity, unity. You have to oppose it, or integrity you have to achieve by various components and various methods. So that is the definition of wound healing. So if you know the wound definition, you will be able to understand or define wound healing easier without any confusion. So wound healing types are healing by primary intention. Neat surgical wounds heal by primary intention usually, unless it is contaminated, unless patient is diabetic, old age. Wound healing by second infection, there is a lot of edema in the wound. So edema subsides, then heals later, or scar heals later. It forms a wider scar. There is second infection. Tertiary wound healing by third infection, takes long time to heal. So this is the basic healing types: primary, secondary, and tertiary healing, or first intention, second intention, third intention. There is a technical terminology you have to remember. It's very simple. So if you understand this, the types, and see that primary suturing. This is the wound is here, primarily sutured. Primary suturing. So how to do that? Delayed primary suturing. So the second is suturing. So primary suturing, delayed primary suturing, second suturing we will do here. And stages of wound healing. These are the different stages of wound healing. Stage of hematoma and inflammation, stage of granulation tissue formation, stage of epithelialization, stage of scar formation and resorption, stage of maturation. These are the different stages, very commonly asked a short note. You can always read in my book what are the stages, 5 stages, 1, 2, 3, 4, 5. Phases are different. See, inflammatory phase, initially inflammation occurs, for neutrophils come for 72 hours. After that, neutrophils will not come. After that, proliferation begins. Initially, hemostasis, coagulation, acute inflammation. After that, it begins in third day, lasts for 6 weeks, proliferative phase. Inflammatory phase only for 3 days or 72 hours. This is the point, is MCQ question, remember. This is also MCQ question. And formation of granulation tissue and repair occurs. Remodeling phase begins at 6 weeks, lasts for 6 months to 1 year or 2 years, 1 or 2 years, 6 months to 1 or 2 years. So it's the final stage actually. So initially, immature scar forms. Immature scar is collagen, the collagen, mainly collagen number 1 and 3 will be there. Immature scars are different, mature scars are different. Initially, immature scars will be formed. Eventually, mature scars will be formed by cross-linking and alignment. Collagen is the main component of a scar, eventually to form. So scar may be initially immature, eventually mature. It takes one or more than 1 year to final scarring to develop. To attain the adequate optimum integrity, not 100%. 100% what it was there earlier will not be achieved, but optimum adequate integrity of the tissue and healing process takes really 1 year actually. So there is a remodeling phase. Then what are the factors affecting the wound healing? Again, it is a very common short note to ask, MCQ question. Date explanation of each factor is there in my manual. You can always go through that. And these are the factors. Infection, pressure, necrotic, foreign bodies, quite common, especially in trauma. Blood supply is very, very important. For any healing, blood supply should be adequate. If there is poor blood supply, healing will not occur. So this is the most important thing. Lymph stasis can occur. Tissue tension, hematoma, large defect or poor apposition, not apposed properly. I have shown this. Recurrent trauma, X-ray irradiated area, site of wound over the joints, back has poor healing. Underlying disease like osteomyelitis, malignancy, immunosuppression, or trauma, long-standing scar, discharging sinus, it won't heal properly. So what type of crush injuries, type of injury, extent of injury, depth of injury, width of the injury area, all those makes a lot of difference. Foreign body, blood supply, near the joint. So anatomical location also important. So where if it is any wound near the joint, you have to immobilize the patient. So that immobilization is very, very important to promote the healing. So blood supply, immobilization, wound debridement, nutrition, and hemoglobin, albumin. That is again important criteria. Hemoglobin should be more than 8 grams is the current criteria. Albumin should be more than 3 grams. So these are the things which you have to remember always when you make the wound healing. But hemoglobin and other things comes under general factors. These are the local factors. So when they ask us a question, factors affecting the wound healing, you have to always tell general and local. First tell about the local factors: joint, foreign body, blood supply, type of wound, extent of the wound, infection, hematoma, all those things, whatever mentioned here. And then general factors: age, obesity, smoking. Smoking delays the healing actually. Smoking prevents the collagen formation. Lot of collagen formation method is there, protein method is synthesis, collagen synthesis is hampered. So proper healing will not occur. Blood supply will be hampered if the patient is smoker. Then again healing will be delayed. Alcohol again decreases the healing, interferes with the healing. Stress, nutrition, I already told, malnutrition, zinc, copper, manganese, vitamin deficiency. Vitamin C is very, very important. Vitamin A is important. Anemia, hemoglobin should be more than 8 grams. Hypoxia, immediate after trauma, hypoxia if it is there, or after surgery hypoxia is there. I should have optimum oxygen saturation, otherwise wound healing will be delayed. Malignancy, wound healing different. Renal failure, again wound healing will slowed. Jaundice, again wound healing will be less. Diabetes interferes with the wound healing with so many factors actually. There will be immunosuppression, is a systemic disease. All metabolic diseases, HIV, AIDS, it also interferes with the wound healing. Steroids, a patient taking on steroid, and many times they apply local steroid ointment and a long time for itching and some reasons. And if any wound occurs, it will not heal. Cytotoxic rise, chemotherapy for the malignancy, cancers, again that will prevent the wound healing. And neuropathies of different causes, maybe diabetes, maybe deficiencies, maybe syndromes, different syndromes, maybe spine injuries, maybe so many conditions where neuropathies will cause a problem with the healing. So general factors and local factors, which you have to remember when you tell the factors. This is always asked, short note, MCQs, Viva, everything. This table is very, very crucial, remember. So wound assessment, X-ray, arterial Doppler or angiogram, then CT scan if you want to do, or MRI of the part if you want to do, how much it is. There's a joint injury, MRI is the current standard. So if there's abdomen injury, CT scan is the current standard. Chest injury, CT scan. Then a brain injury, scalp injury, to see that whether it's a skull is injured or not, fracture is there or not, CT scan. So that is how exactly discharge study, other imaging, CCT, ultrasound, MRI for joint and other areas, Doppler study, ultrasound, discharge study, X-ray part to see fracture initial, hematocrit, clinical assessment is very good, depth, extent. Accordingly, you decide what exactly you are going to do. Of course, if patient is diabetic, then diabetes assessment, immunosuppression assessment, hemoglobin, hematocrit, everything is important, electrolytes. Depending on the extent of the injury, severity of the injury, systemic involvement, everything counts as individual case-to-case basis. That is the important thing which you have to remember. So how to manage? So you know how to assess. You know, clinical is important. Eventually imaging and other things also. Biochemical assessment also important, I already told. So how to manage this patient? Wound cleaning is very important. First thing is clean the wound. How will clean? Warm, normal saline wash. Adequate warm, normal saline wash. Use normal saline. That's most important. And time principle, remember. T is the tissue, I is the inflammation, M is the moisture imbalance, E is the edge of the wound. Prime principle or approach. So, adequate tissue debridement, inflammation control, moisture imbalance, if it is there, it should be dried up. Edge of the wound, edge is progressing when you have to do a wound debridement. So, accordingly, tissue, inflammation, moisture imbalance, edge, time principle, that is very, very important in many. So what is time? Components of time principle is a very common MCQ question or short note. Tissue, inflammation, moisture imbalance, edge. Tissue, inflammation, moisture imbalance, edge. These 4 components you have to always remember. And note, biofilm. What is biofilm? It's very commonly asked MCQ. It is a complex, if there is a biofilm in an ulcer or a wound healing will be delayed. It is a complex microbial community, bacteria, the protective matrix. Bacteria creates a protective matrix with the sugar. This is called as glycocalyx, and which covers the layer over the wound, and it prevents the wound healing, and rather it multiplies. It creates an environment where it can multiply and progress further against the human or wound healing process. So it is biofilm is against wound if the adverse effect of in a wound if it is there. It should be removed properly, often with proper wound debridement. You have to remove the wound, very important. So protective, it provides a protection to the bacteria, not to the ulcer, not to the wound as such. So it is against wound healing. So remember what is biofilm also, that's important. So specific management, primary suturing, delayed primary suturing, secondary suturing, I already showed the photo there earlier. Please go through that photos. Here you can see that. I'll just see the photo, show the photos to you people. So see that this is the primary suturing. See that immediately suturing. This is the second delayed primary suturing. See that edema is there. So suture later. So this is the secondary suturing after 2 weeks or 3 weeks. And everything is infection was controlled, everything. Then see that this is sutured here. With the necrotizing fasciitis, this patient, and diabetic, both diabetic patient, this is sutured here later. Fasciotomy done, then sutured here. So this is the primary suturing, delayed primary suturing once edema subside. Secondary after 2 to 3 weeks. 3 weeks. Once infection, everything controlled, you feel that bacteria discharge culture or tissue culture is negative for bacteria or less than 10 to the 5 per gram of tissue, streptococci. So in such a situation, you can do a secondary suturing, or a wider area you have to put a graft or sometimes flap. Sometimes you have to do a vac therapy also. So primary suturing, delayed primary suturing, secondary suturing. So these are the things which you have to remember. So wound debridement. So what are different? There are different methods. Usually mechanical debridement. So either remove all dead tissue until it bleeds. It's a concept. Then there are many medicines are there. Local application to do the debridement. There are maggot therapies there. Cultured maggots are there. You can put maggots into the wound to heat. So you know that maggots eat only dead tissue, not live tissue. So it is said that it cleans everything. It's only dead tissue. So that live tissue will be there. Maggot therapy. Regular dressing, Usol is a full form Usol. You have to remember Edinburgh University solution of lime contains calcium hydroxide, bleaching powder, and boric acid. It is colorless but with a blue tinged bottle. So you can use Usol to remove the slough. The slough is the dead soft tissue in situ, and or you can put a warm water in the bucket, put a Usol and dilute it, and put the leg or wound area, usually in the leg, in the lower limb. Put the dip the limb into the Usol solution, dilute Usol solution for usually 20 minutes or 30 minutes. Then do the dressing. That is called Usol bath. So it's very commonly practiced in the surgical ward. Good old method called as Usol bath. Dilute Usol in a warm water. Local applications are there. So many regular dressings you have to do. Maybe depending on situation. Lot of discharge daily or twice daily, or once in 2 days, once in 3 days, depending on the situation, depending on how wound looks like. Then you take a call. Then once granulate swell, wider area, you have to put a skin grafting. Usually split skin grafting, tears grafting you have to put. Usually Humvee's knife is used, Eastman blade or Down's blade is used. Usually thigh is the donor area. Sometimes depending on the situation, other area can be used. If it's a small area over the joint, over the specified areas, then full thickness graft you can use, because graft loss will not be there. Mobility of the joint will be maintained. In such other ways, we have to do a vac therapy. See that vac therapy. This is the vac therapy. See here, vacuum, negative pressure wound therapy, vacuum assisted closure, vac therapy, vacuum assisted closure or negative wound therapy. So it creates the vacuum up to 250 millimeters of mercury. So draws all infected fluid. It promotes epithelialization. It promotes the granulation tissue formation, promotes healing. After usually 4 or 5 days you wait. Canister is there to collect everything. And after that, if you open the wound, it will granulate well. Then you can put a graft or flap, depending on the location, situation, and your choice as such. So flaps you can use. Then eventually, physiotherapy and rehabilitation is also equally important, remember. So there is a specific management, remember, usually very standard method actually. I'm not going to detail what all ointments, local applications you go through. You can go through my book. Everything is detailed in my book, Manual of Surgery. And specific management, general, antibiotic, do the pus culture or tissue culture, then sensitivity, you go through that and what antibiotic you are going to give. Blood transfusion, that is hemoglobin is low. Nutrition is very important. Large, big, major wounds, you have to do is put a central line, then total perennial nutrition is required. Once your patient is oral, you can put a nasogastric tube and oral nasogastric feeding you can do. Other is oral feeding, but nutrition is very, very important. Mainly high protein diet. There will be catabolic in a major injuries. You have to switch over to anabolism because negative nitrogen balance is very, very dangerous to the recovery and the patient as such. So high protein diet, both balanced diet, carbohydrate, high protein, fat, other elements, essential elements, everything should be given to the patient. Analgesic pain is a very crucial part, so the psychological will be upset. Good analgesic is very important. Tetanus toxoid, anti-tetanus globulin in major crush injuries, anti-gas gangrene serum also maybe have to give depending on the level, where exactly patient had injury. Contaminated area may have to do that. Management of diabetes, patient diabetes, hypertension, other lines, call physician for that. So it is a treatment strategy is a very complex. You have to involve many people. Physiotherapist, diabetologist, physician, sometimes cardiologist if cardiac problem is there, and yourself, then regular dressing, regular monitoring patient, transfusions, central line, nutrition, hemoglobin, everything is important. Local factors, everything is important, remember. Doppler or imaging maybe have to do the local area. So compartment syndrome is another type. I'm not going to detail, just go through my manual, but it is important. It's the raised intra-compartmental pressure within the limited space, commonly observed in leg, forearm, arm, thigh. Pressure more than 30 mm is significant. It involves muscle, nerves with severe ischemia within it and rapidly progressive. Remember, it is very rapidly progressive compartment syndrome. Within the small space, pressure increases so much that it compresses the blood supply. Muscle goes for a severe ischemia, and it may release myoglobulin. It may enter the circulation and renal, kidney, and acute renal tubular necrosis and acute renal failure can occur, may kill the patient. Remember, this is the most dangerous thing. And passive stretching of the muscle will be very painful. There is a clinical sign. Important. Passive stretching of the muscle causes severe pain. That is an important clinical sign for compartment syndrome. Pressure is important. Remember, more than 30 mm mercury. Pressure is assessed by placing the catheter or catheter pressure monitor, small fine catheter or tube we place under the muscle, across the skin into the muscle or under the muscle. Then connect to the water manometer and see how it is the pressure. Needs urgent fasciotomy to decompress. Otherwise, you will lose the limb, patient, renal failure, systemic problem, sepsis, everything can occur. Sepsis, gangrene, ischemic contracture later. The muscle goes for ischemia, then Volkmann's ischemic contracture in the upper limb or ischemic contracture anywhere in the limbs. Renal failure, multi-organ dysfunction syndrome, all those things can occur, remember. So crushed injury and cut syndrome, your body part is getting squeezed between the high forces, causing major injuries like extensive laceration, tissue loss, fractures, organ injuries, sepsis, renal failure, shock. This is the crushed injury. Crushed injuries are like major injuries, major road traffic accidents, then earthquakes, building collapse, all those areas, stone falls over the body, then crushed injury occurs. There is usually major injuries, rather difficult to manage, long-term hospitalization, all system has to manage, the area where crush has occurred also has to be managed. So all the things are very important. Syndrome causes muscle ischemia, renal failure with the acute tubular metabolic drain with sepsis. Everything is called syndrome. Crush injury syndrome, almost similar it is. But management, critical care, admission, critical care, blood transfusion, systemic management, antibiotic, then local management depending on the location, pelvic crush injury, limb crush injury. Sometimes they may land with the amputation, sepsis, renal failure, respiratory complications, liver failure, everything can occur. Depending on the age, associated problems, morbid status, everything. So cost factor is also important. Long hospitalization, repeated surgery, not one surgery, wound debridement, then later reconstruction, treatment for the fractures, everything is later. So many repeated procedures are required in this patient. Ventilator may be needed. So it's a major problem, remember, crush injury, not an easy problem. It takes long time to heal. Many interventions are required. So deglowing is a little different, where it may be open or closed deglowing injury. Open, it get deglowed like this, everything else. So deglowing injury. There are two types, open and closed. Open is a common thing. Deeper injury, deeper part muscles may get deglowed, but skin muscles or fascia may get deglowed, but skin is intact with a large hematoma, discoloration is there. So often difficult to differentiate from the hematoma and closed deglowing injury. Almost similarities, but inside disruptions are different. Hematoma is just a clot, small oozing clot, whereas closed deglowing injuries are fascia may be avulsed inside, muscle may be avulsed inside, whereas skin is intact, but look is similar. That is what is meant of closed deglowing injury. This is what I said, open and closed deglowing injury. Closed deglowing injury may be missed for something else. Your assessment may go wrong. You think it is simple. It is not so. Deeper injury may be dangerous. It may cause sepsis, anaerobic infection can occur, gas gangrene can occur. It may thread infection, necrosis fasciitis can occur. So beware of that. It looks simple actually many times. Unless you assess, do ultrasound of the area or MRI of the area to assess properly. If it's a similar like crush injury, radical wound is critical care, systemic and local management are important. See, students note, scar is final effect of the wound healing. Wound healing, I already told. So final effect is scar. Scar is final arranged formation of collagen bundle type 1. This is the MCQ question. Final scar, even mature scar. So before that, immature. So initially wound healing occurs, different phases. You have already shown inflammatory, proliferative, remodeling phase. So in remodeling phase at the end, immature scar occurs. That is type 3 collagen. Once a remodeling phase occurs, maturation of scar usually takes 1.5 years. That is type 1 scar. So final scar is type 1, immature scar before that is type 3, and mature scar is always type 1 again. So scar, final scar and mature scar is same. That is type 1. Whereas hypertrophic scar and keloid type 3. So immature scar, hypertrophic scar, keloid type 3 collagen. Mature scar or final scar is type 1 collagen. That is the MCQ question. Remember, don't get confused. So scar can be stable or unstable. So unstable is very, very important because unstable cause a lot of complication, infection, pain, disability, and over that it may long-standing unstable scar may turn into marginal ulcer. That is a well-defined squamous cell carcinoma arising from the scar. So no lymph node spread, no blood spread. So marginal ulcer is a well-defined squamous cell carcinoma arising in a chronic scar, where scar type is unstable scar of long duration. Unstable scar is more dangerous, remember. Scar should be assessed clinically, whether linear, supple, thin, is healed by primary intention, or wider, firm, irregular, healed by secondary intention. I already discussed these things. Hypertrophic scar and keloid are pathological type of scar. That's what I am going to discuss now. So what is keloid? Word meaning is keloid like claw. It's a very common short note asked. All these areas are common locations, mainly sternum, chest wall, upper arm, ear. This is 4 areas, very common area. It is familial often, genetically predisposed. It is common in blacks, remember, and extends beyond the normal skin. If this is the scar, it extends beyond the normal skin here. Extends beyond normal skin. And it is vascular, painful, tender, itching is there. So it is progressive beyond 6 months, where hypertrophic scar does not progress beyond 6 months. So progresses beyond 6 months is very important. Type 3 collagen, remember, mature scar is type 1, final scar is type 1, immature and scar is type 3, keloid is type 3, hypertrophic scar is type 3, where synthesis is 20 times more than normal. Most important, 20 times. Again, MCQ question. Common in females, tender, progressive, dark colored, vascular, itching, continue to grow after 6 months, hyperesthesia, ulceration, already told. So treatment is, the recurrence is very high. You can't do surgery straight away for keloid. Remember, it recurs definitely. It recurs wider area. Intraocular topical injection, vitamin A, C, E, silicone gels, local application and oral. Topical retinoids are helpful. Laser, give steroid injection and exercise it. Again, continue steroid. That's one modality. So without steroid injection, you have to suppress the collagen synthesis, over synthesis. Some people to give radiotherapy, excision, continue radiotherapy. So all those combination permutations are there because very high very, very high recurrence rate. It's very important. You have to tell the patient recurrence is very likely. There's a point which you remember, very commonly asked, short note, MCQs, Viva, type 3 collagen, 20 times. These are the two things which are very important. Hypotrichosis is different, it's lesser problematic, usually lasts for 6 months and only limited to the scar tissue, unlike keloid it goes beyond, and it is not vascular, no itching, not usually painful and tender, sometimes of course, but not as much as a keloid. And it's again type 3 collagen, but the proliferation is less, 6 times, whereas keloid is 20 times. It's common in children, where that is common in females, equal in both sexes, no racial relation, that is racially genetically predisposed, familial, pale, not tender, not vascular, no itching, spontaneous remission can occur, won't go beyond 6 months. Pressure garment, steroid injection or treatment, but can't turn into marginal ulcer. Keloid will not turn into marginal ulcer. Hypotrichosis scar can turn into marginal ulcer. This is already told what is marginal ulcer. Unstable scar of long duration. So differences you should remember, keloid and hypotrichosis scar. My book, there is a table, you can always go through that. So scar healed by second intention, hypotrichosis scar, keloid, all these things. Remember this one. These things are very, very important. So problems with the wound healing, just see second intention, hypotrichosis scar, keloid, how it looks like that. It extends to the normal area. Linear scar of it looks like it may be marginal ulcer. This may be proliferation with the marginal ulcer. So these are the different looks of different types. Just have a look, very clear it is. And problems with the wound healing are wound infection, dehiscence, wound contractures, very difficult to manage. Hypotrichosis scar, keloid, I already told, pyogenic granuloma formation. This is how exactly it looks. Exuberant it is. Pyogenic granuloma, swelling, it cannot bleeds actually. Requires excision. You have to take a biopsy up also. So these are the problems with the wound healing, very commonly asked short note or MCQ, remember. So students, please go through my manual of surgery. Everything is there about wound, and the book contains everything as for CBME syllabus, from general surgery, vascular, venous, endocrine, thyroid, breast and parathyroid, and gastrointestinal surgery, everything. And specialties, urology, neurosurgery, cardiothoracic surgery, and with the footnotes, lot of quotations, lot of photos and illustrations with the management concepts, everything is there. And it contains basic operative surgery also for students, UGs, and instrument also it contains anesthesia and adjuvant therapy also. So everything as for CBME syllabus, it is covered fully with a lot of photos, illustrations, and each chapter has got an online MCQs which will be helpful for your competitive exam like NEET. So please have my manual of the best selling book as far as surgery is considered. My clinical methods in surgery is very, very useful for learning how to examine a patient. General examination, hernia, breast, thyroid, swellings, ulcer, vascular diseases, venous disease, arterial disease, abdomen examination, rectal examination, basic orthopedic examination, specialty examination, and also it contains the differential diagnosis in a tabular form. And so please have my clinical method in surgery. It also, each chapter has got a QR code which gives the video showing the examination of like hernia. QR code, when you press, you get the examination of hernia, like thyroid, examination of thyroid, like swelling, examination of swelling, like that. Everything is covered. And my operative surgery book, current edition, new one, 2-volume extensive book with more than 10,000 illustration and photos, will be helpful for whoever surgeons who are operating, step by step, all small procedures to major procedures. It is covered everything, so you can, before going to surgery, you can learn this one. My loss of tissue approximation, it shows very clearly tissue suturing, small atlas, 100 pages with the video, how to approximate tissue, skin, deeper plane, laparoscopy sutures. You can learn with that atlas, very well technical aspect. And my YouTube SRB Surgical Insight website, please subscribe my website and share with your friends and colleagues. Press the bell and also daily learn the surgery by day-to-day basis with the small lectures or small MCQs or spotters, so that you will learn surgery on daily basis with interesting. And also once in 2 weeks live sessions about where student will present a case, 1.5 hour session with interaction live, and how to manage a case, how to present a case. So practical exam will have the idea, and senior faculties other than me also will be there in live. And if you join this live session, you get a certificate. It will be very useful for you. And my Diginor lectures are there through JP Publishers. Entire surgery is covered. Examination, operative procedures, all chapters as for CBMS, specialties also. It is covered entirely around 220 hours lecture. 1 year you can purchase, so that you can learn surgery properly, fully, without any problem. So have my lectures. So please subscribe my YouTube channel and learn surgery on daily, day-to-day basis. So students, I hope you have understood this lecture very well. Thank you so much.